So today we are going to start the examination of motor system, and let's start. So I'm not talking about this motor system. This is of automobiles, right? I'm talking about this one, which is even more complex than the system in automobiles. So a variety of nerves, a variety of response systems, a variety of stimuli, so as to make us do activities, right? The examination of motor system plays an important role in your practical examinations. This topic was demanded by some of the juniors of my college, and today we are going to cover that topic in a very simplified way. And I've written all the things. Just will see, and the practical aspects I will try to demonstrate as much as possible. Although I don't have any subject present over here, so as to demonstrate that. No problems. Will understand easily, right? Okay, let's start. It will be a small lecture, not much time will take, and we'll finish it. So, first of all, if you're starting any examination, just know that you have to take the consent of the subject. So, first thing you have to stand when the examiner calls you and tells you that इसका मोटर सिस्टम एग्जामिन करके दिखाओ, ठीक है? तो पहले क्या करना है कि पहले जब आते हो, फर्स्ट make sure as much as possible your classmate will be the patient, right? You have to demonstrate the things upon him only. Okay, so whenever you come, first stand on the right side of the patient. Okay, make the patient sit, make him or her comfortable, and stand on the right side. The first basic rule: you must be appropriately dressed, your shoes polished, and examination hall, if you're going to the examination hall, do make sure your attire is professional and completely as a doctor, right? So first you have to introduce yourself. First you have to introduce in the native language. Importantly, do remember that sorry, okay, that some examiners tend to tell you that you should examine the patient in native language. So make sure to ask the examiner if should I use English or Odia or whatever language. If he tells you do whatever, then you should use English. English is a bit more modern language as compared to your mother tongues and all, right? No offense. Okay. So you have to first introduce yourself. You have to first tell that you are the doctor, and today we are here to examine you. And today I'll be doing motor examination upon you. Can I do that? Okay. The patient will consent by yes. Sometimes we have something called as an implied consent. Implied consent. Implied consent means the patient is coming to you, right? The patient is coming to you to be examined by you. So we assume that the patient has the consent already. So our doctors in our Indian clinical practice, uh, generally we don't take any consent for usual examinations like your motor system examination or your any examination of sensory system and all. So we basically assume that we have the patient has given us consent because he or she is coming to our clinic so as to get checked, right? But in examination, you have to take consent because it is a very, very good practice, right? So implied consent is necessary. Okay, let's start. So you took the consent, you took all of the things. First thing, the examination was do remember the sequence. First thing, you have to check the bulk of the muscle. You have to check the bulk of the muscle. So, to why the examiner will ask, why will you check the bulk of the muscle? Bulk of the muscle, remember, it is checked to check if the muscle is wasted or if the muscle is atrophied or if there is a hypertrophy of the muscle. Hypertrophy means the muscle is more okay in mass, and muscle atrophy or muscle wasting means you will see a diminished amount of muscle mass present in the body of the patient, right? It has a very clinical implication. So measuring tape is must. You have to take measuring tape to their examination hall. But if you don't get any measuring tape, then you should be able to tell the examiner that we require the measuring tape, and measuring tape is used. I don't have a measuring tape now. Otherwise, I would have demonstrated. If this is the muscle, okay. So you have to first put the measuring tape like this. and check the bulk of the muscle. So which muscles measure forearm on both sides at its widest part? Remember the statement, widest part. This part is important. Widest part means if this is the forearm, okay, this is the widest part. Just can you see me? Okay, this is the widest part. This one. So to check the bulk at the widest part, right? And both sides, importantly, both sides. So to take the measuring tape, check the width on the both sides on the widest part. Do remember this buzzwords which I am telling you. Measure arm on both sides at the broad part, arm also at the broad part. So you have to check each and every muscle. You should have to tell the examiners that you will be checking each and every muscle. Of course, the examiner will stop you at arm and forearm, right? But if he tells you that why are you checking the bulk of the muscle, or why are you checking the width of the muscle, okay, then we have some you should be able to tell that we have some conditions, we have some pathology, we have some diseases in which there is an increased bulk or there is a decreased bulk of the muscle, right? So we have some conditions of muscle wasting. Muscle wasting means the muscle is being, the mass is being diminished. So what are the examples? Cachexia. Cachexia means a starvation of the muscle. Okay, starvation. A state of starvation is called as cachexia. You must have heard cancer cachexia. Cancer cachexia means in cancer, basically the body mass and all they diminish due to irradiations, right? So cachexia is one of the causes, nutritional causes. Prolonged hypotonia. There is a hypotonia means hypo means less, tonia means tone. So if there is a decreased tone of muscle, then it is called as hypotonia, right? Inflammation, any inflammatory condition tend to decrease the bulk of the muscle. And neurological disorders, of course, polio. Polio is one of the examples in which there is a decreased wasting or decreased mass of muscle, right? Then we have some hypertrophy condition. Hypertrophy means the mass of muscle, the bulk of the muscle increases. The weight of the muscle or the width will increase. Okay. In gym goers, okay, very important. It is a pathological or physiological. It is a physiological cause. Physiological. So in gym goers, what happens is that just a minute. Okay, we are back. So in gym goers, what will happen is that physiologically there is a increased mass of muscle. Okay, of course you will you know this all. Okay, you lift the dumbbells, you do that pull downs, pull ups, and there's a white source of thing. I'm a gym goer, but you see my muscles then absent or disappear. Okay, athletes of course physiological response in muscular dystrophy. Duchenne muscular dystrophy. So we have conditions like Duchenne muscular dystrophy and a condition like Becker's muscular dystrophy. So here also the bulk of muscle starts to increase, right? So remember gym goers, athletes, and Duchenne muscular dystrophy. Just one is enough, right? So there is an increase in bulk of muscle here. So these are the conditions in which the bulk of muscle you have to check. You have to remember what to do. You have to remember why are you doing this examination, right? So let's move on and talk about tone of the muscle. The examiner will ask you in that sequence only. He will expect you. So you answer in the specific sequence. Bulk of muscle is done. Then we come to tone of the muscle. Okay. B, then T. Okay. Tone. Muscle always remains in a partially contracted state and it is due to low frequency asynchronous discharge of gamma motor neurons. Okay. So you know that a muscle spindle is innervated by the A gamma motor fibers. Okay. A gamma motor neurons. So A gamma motor neurons, they have a resting membrane discharge. Okay. They discharge at a very, very tiny rate so that the muscle will remain at a partially contracted state. Important thing is that partially contracted state, not fully contracted. This muscle which I'm this one any muscle radialis or my pronator teres, any muscle which I'm taking is in a particular state, is in a particular uh, not like that it is flappy, not like that I'm in octopus, right? The muscle is having a particular shape, and this particular shape of the muscle, which is called the tone of the muscle. And this is due to what is the reason? That, remember, this statement is very important. This asynchronous, low frequency important, asynchronous discharge of gamma motor neurons. Asynchronous discharge of gamma motor neurons. This is important. And this is called as physiological tetanus. Pathological tetanus, you know. Okay, physiological tetanus is this one. Okay, so we have some conditions in which there is a decreased tone or if there is an increased tone, right? So we can have hypotonia or we can have hypertonia. Hypotonia means decreased tone of muscle. Hypertonia means increased tone of muscle. Hypotonia, in which conditions? Physiologically, we have sleep. In sleep, you get fully relaxed. Okay, you move about to your dreamy worlds and dream whatever illogically, right? So hypotonia is seen in your sleep. Then element lesion, lower motor neuron lesions. Lower motor neuron lesions, you know, in element palsy. Okay, uh, if you have a exam and here they tend to ask you the differences. They tend to ask the differences between element lower motor neuron lesions and upper motor neuron lesions. Difference table is very important, right? We have a table there, lower motor neuron, upper motor neuron. I hope you have seen the table, and if you haven't, do see the table from wherever you get. Maybe I have made a video on one shot on physiology, so I had made that table. Okay. So I had taught that, I hope. Okay, no problem. Just a trick, remembering trick. Element lesion means lower, lower means down. Okay, so here we down, and upper motor neuron is up. So up, everything up. So lower motor neurons lesions, and down means what I mean. We have our first of all hyporeflexia. All the reflexes get slower in lower motor neuron lesions. Upper motor neurons means hyperreflexia. All the reflexes gets exaggerated, right? Then element lesion, what will happen? Your toes go down, which is the normal response. You know what is the response? Babinski sign. Babinski sign, you know that when you stroke the medial side and that your toes will go down, right? And upper motor neurons lesions, your toes are like this, it will fan out or it will move up. It will move up and fan out, right? So here Babinski sign is positive, here it is negative, right? So lower motor neurons, what will happen? There will be hypotonia because everything down, right? Hypotonia. And upper motor neuron lesions means there will be hypertonia. This is the concept you have to remember. Okay. Hypertonia is seen in, there is an increased tone of muscle is seen in brain disease. Will be seen in any brain disease. Okay. It will depend upon the types and severity of the brain disease. We can't comment on a specific disorder. Okay. Yeah. So how to check the tone of the muscle? Bulk of the muscle, you know how to check. You take a measuring tape, put on the both sides on the widest part. First you put on this side on the widest part, then you put on this side on the widest part. Right. Both sides are important because sometimes you will get left side hypertonia and right side hypotonia. Anything can happen, any condition, anything can happen, right? Okay, so tone of muscle, how to check? Ask the patient to relax his hands totally. First the patient will sit like this, relax his hand totally. Okay, the patient will sit like this. If I am the patient, I will first put my hand like this, I will relax my hand. Hands are moved, flexed and extended. Okay, means if this is the hand, ask the patient to do like this and do and push the hand like this. Okay, so slight resistance is felt. A slight resistance is felt as you push the hand, and then if the patient is doing like this, then extend the hand. Then also a slight resistance will be felt, right? But whenever if there is a hypotonia, then you will face no resistance in moving, extending or flexing the hand. If you are flexing the hand, it will like this, and extending it will be like this abruptly. And if there is hypertonia, then if you start flexing the hand, if you start flexing the hand, you will face more resistance. You'll face more resistance. And extending also, you are facing more resistance. Understood? Okay. Yeah. So here we have some rigidities present. Okay. Some specific disorders have some type of hypertonia and hypotonia. Okay. Like in Parkinson's disease, you must have read, in Parkinson's disease, we have lead pipe rigidity. Okay. The rigidity is like lead pipe, and cogwheel rigidity means if we are flexing the hand, it will be like this. Okay, it will be like this. Means the spokes of a wheel, the spokes of a wheel, are abruptly moving. Okay, so it will be like this, spokes of a wheel. Understood? So this one, this lead pipe and cogwheel rigidity is in Parkinson's disease. You have to understand. Third thing, we have to check the strength or the power of the muscle. To check the strength or the power of the muscle. First thing, bulk. Second thing, tone. Third thing, strength. Right? So, strength of the muscle for, let's say we take two muscles here. We have to check the strength of each and every muscle of the body. But the examiner will ask you just a simple thing. You tell the examiner, sir, that I am checking the bicep strength of the patient. Okay, and start doing this. No need to worry that you have to check each and every muscle, each and every strength of the muscle. Right? Let's say for biceps. Okay. For biceps, instruct the subject to flex his arm against the passive resistance offered by you. Okay. So for checking the strength of the biceps, this is the biceps, right? This is the biceps. And for checking the strength of the biceps, ask the patient to flex his arm. The patient flexes his arm. Okay. And you offer passive resistance. You offer like this. You push like this, and the subject is flexing the arm. So you are checking basically the strength of the biceps. You do like this, you offer resistance, and the patient will start to flex. So you will get a idea of the strength of the muscle. First, for triceps, biceps is the uh, whatever the muscle is causing, whatever movement the muscle have to do, like the muscle has to flex the arm, right? Biceps is the flexor, and triceps is the extender muscle, right? So you have to check whether the muscle is performing its action completely or not. Okay. So for checking the strength of biceps, you are pushing the arm so that the biceps can flex. So then biceps can flex the arm. First you check its strength. If you're checking the triceps, what you have to do? You have to do opposite. Okay. The patient has to extend the arm. The patient has to extend the arm. And you have to push it here. Okay. So that the patient have to extend the arm, and you have to push it this direction. So check the strength of the triceps. This opposite. Right. Okay. So this is about the strength or the power of the muscle. Okay, you have to check the strength or the power of the muscle according to, and every muscle have its own way of checking the strength. So we have a grading of strength, not much important. Just let me state it. Grade 0 means no movement at all. Grade 1 means flinching of muscle if movement is attempted. Means the muscle will just flicker. Okay, the muscle will just twitch. Grade 0 means no movement. Means the muscle is completely gone. Okay, the muscle is completely wasted. You do like this, and the muscle is like that. In this, just passive movement. Grade 1 means flickering of muscle. If you put some resistance, the muscle will start like flickering. Okay, it will be like this, but it will it will just fire an impulse so that it can flicker like that. Grade 1 means movement occurs but not against gravity. Here movement will occur, okay, but it can't resist the gravity. It can't resist the opposite movement which you are trying to put. Then grade 3, movement occurs against gravity, it will be good. Movements occurs against gravity with moderate resistance. You put in resistance, it will be like moderately resistant. And grade 5 means movement occurs against gravity with strong resistance. So the movement can occur easily. So 0, 1, 2, 3, 4, 5 grades of strength. Not much important as per this is discussed. Okay, this is an important part. Then we have to check coordination of the movement in various conditions, like you must have seen alcoholics going that way, two steps forward, three steps backward, like that. Okay, I got reminded of that question in physics. Let's not go into that. Coordination of the movement. Coordination of the movement means how the movement you are coordinating. You are not a robot, but you have a good coordination, right? You can't coordinate the things like anything, but you have a particular way of doing the things and coordination of the senses, right? So for checking coordination, in which conditions coordinations are disturbed, basically we have cerebellar lesions. In cerebellar lesions, coordination is disturbed. Okay, basically. And cerebellar ataxia is often associated with alcohol use. Okay, let's start. So first we have a something called as a finger nose test. Something called as a finger nose test. What to do? So uh, first what I'll do, let me sit like this. Okay. So here we have I have a finger here. Okay, and try to touch the nose. Then I can easily touch the nose, right? No problem in that. Then I have to close my eyes and then bring the finger to that width and then touch the nose. Means bring the finger here and then touch the nose, closing my eyes. Then also you can easily do this. Okay, just close your eyes and just try to touch your finger. You can easily do this. But a person with cerebral ataxia will find it very, very difficult so as to touch the nose. He will just start like this, bring, and then will find the nose. Will tap other areas, right? So this is the finger nose test, right? So performed with eyes open and then with eyes closed, and the person with a cerebellar ataxia or any abnormality which is affecting the cerebellum will be finding it difficult to do that. Then ask the subject to draw a circle in air with both hands. Okay, means the person will start to draw a circle in air with both hands, with this hand also, with this hand also. Okay, basically, the person cerebellar ataxia will find it difficult to draw the circle. They will move their hand randomly. They can't draw a circle. Okay, this is one thing. Then diadochokinesis. Diadochokinesis is a very important thing. Okay, ask the patient to do alternate movement with his both hands. Alternate movements with his both hands means, okay, ask the person to put his hand like this and do this and this. This one. Ask the hand to ask the patient to say bye. The patient will try to do like this. The patient with cerebral ataxia will do like this, one side only. Or ask the patient to clap like this. This just this one you can tell. This one you can tell. Okay, kacha papat pakka papat. But the patient what will do? The patient will do like this, or the patient will do like this. Okay, you understood? Then we have a something called as a leg rubbing test, which is also called as a heel knee test. Rub the right heel over the shin of the left leg and go downward like this. Okay, you just if you have a leg and you have to rub the right heel over the left leg. Okay, so rub the heel like this. The patient will be not able to coordinate this movement. Also, will go like this and this. Okay, understood. So this is a leg rubbing test also, not much important. Diadochokinesis is very, very important. Your examiner will fail you if you don't tell this, because this is a very famous characteristic in your cerebellar lesions where this is lost. And this diadochokinesis is basically a what can I tell? A test for alternate movements. Test for alternate movement. Okay. Then we have something called the tandem gait. Tandem gait. TANDEM gait. It is not visible. Tandem gait. To check the coordination of the lower limbs, we have to perform a tandem gait test. Tandem gait test means, let's say here is one foot and here is the next foot. So you have to ask the patient to put the toes of the first foot behind the heel of the second foot, right? Like this, and walk like this. This type. You must have walked like this in your childhood. I don't know if you have guys done like this or not. I have worked many times like this. Okay, okay. So this is a tandem gait test, and the person which is normal can easily do this, but a person with cerebral lesions will find it very very difficult to walk like this. Right? Then we have something called as a Romberg sign. Okay, Romberg sign is also done for 8. Okay, 8 checks will cover in another video or so. Let's see. And but here, what is the importance of the Romberg sign? So first, you have to ask the patient to stand erect with the heels closed and eyes open. Okay, the person will stand with like this, stand like this, very erect and eyes open. Okay, the patient will stand straight. Obviously, the patient will stand straight. Ask him to close his eyes. Ask him to close his eyes. Person closes his eyes and stands erect. Then, if he can stand erectly, if the person is normal, then he can do this easily. If the person is normal, he can do is close his eyes and stand. You must have done in your prayer classes, right? You that sing the prayer in the morning assembly that time in your school and stand erect with your eyes closed, right? No problem in that. The normal person will stand erect, but if the person have a cerebral lesion, if the person has a cerebral lesion, if the person is cerebral ataxia, then what will happen? The person will always sway. The person will sway if his eyes is closed, if his eyes is open. The person will always be like this, like this. He or she will fall, tend to fall upon one side. Okay, the person will be finding it very very difficult to stand erect, just to stand erect, right? If the person has sensory ataxia, the person will sway with eyes closed only. Okay, the person has sensory ataxia, the person will sway with eyes closed only. The person can stand erect if his eyes are closed, but the person will find it very difficult if his eyes are closed. Right? The person can stand erect if his eyes are open. Sorry, and he or she will sway if the eyes are closed. This is about cerebral ataxia and the Romberg sign. Romberg sign is a very important sign which you have to demonstrate to your examiner often, and they tend to ask this also. So you have to ask the patient to stand erect and open the eyes. If he has cerebral ataxia, he will sway to other sides. Then ask him to close. If cerebral ataxia is ruled out, if he doesn't sway, okay, then ask the person to close his eyes. And if he tries to, if he sways here, then he has sensory ataxia. But if the person can stand erect with eyes open, if the person can stand erect with eyes closed, then he has no ataxia. Then the person is completely normal, right? Okay. Then we have something called as a gait. Gait means your walking style, right? Walking style. Gait may be altered in various conditions. Like if you are a model, then you have to walk that catwalk and something sort of things. I don't know. Okay, just I got reminded. That's all. Gait, walking style. Okay. So we have something called as a spastic gait or a hemiplegic gait. Hemiplegia means a half paralysis sort of thing. Okay. So we have spastic gait or hemiplegic gait. Patient changes his leg. Okay. Uh, okay, over the ground while walking. Okay, the patient will try will be finding it very difficult to walk. The patient will sway to one side while walking. Okay, the patient will sway to one side while walking. This is a spastic gait. Okay, you know about spastic paralysis. Spastic paralysis is seen in spastic paralysis seen in human lesion. Okay, so pyramidal tract lesions are commonly causing the spastic gait or a hemiplegic gait, means a half paralysis type of state, right? Then we have something called as a stampling gait. Okay, we have something called as a stampling gait means it's seen in sensory ataxia. You can describe the gait, so I put a GIF here. Okay, so let's see the GIF how the patient is working. Look at this. The patient is working stamplingly. Okay, like this. One leg will move a bit higher up and one leg is moving at a little lower level if I want to describe the gait. Okay, the patient is walking like this, stampling gait, seen in sensory ataxia. Understood? Nothing to understand here. Just to watch the GIF and enjoy. Okay. Then we have a drunken or reeling gait. A drunken gait. You must have heard the term drunken gait. People who get drunk basically in after Saturday night they get drunk and walk upon the streets. You must have seen some people like that in your real life also. So drunken gait or the reeling gait is seen in cerebellar lesions. Is seen in cerebellar lesions. For example, your after alcohol intake, after alcoholism. Okay, and it is also called as the ataxic gait. Ataxic gait. Ataxia means a inability to walk straight. Inability to walk straight is ataxia. And ataxic gait or the drunken gait or the reeling gait, just remember the words reeling, drunken, and ataxic are seen in cerebellar lesions. Four words you have to understand. And let's see the how the patient is walking. See like that. Funny, right? Okay. Yeah. Then we have something called as a Festinand gate. If this is not visible, let me write it. Festinand gate. Festinand gait means the patient will walk in short, shuffling steps. The patient will walk with short, shuffling steps with a stooped posture. Stooped posture means bend posture and short steps. The patient will walk in short steps, right? Stooped body and body has a tendency to fall towards the center of gravity. This is COG means center of gravity. The body will be imbalanced and the patient has a tendency to fall up like this. Okay, the patient can fall upon the center of gravity and the patient will stoop the posture to maintain his center of gravity. The patient will stoop his posture to maintain his center of gravity and this Festinand gait. This Festinand gait is seen in Parkinson's disease. Important causes Parkinson's. Parkinson's disease. Parkinson's disease, we have the patient and the stooped posture. Let's see how the patient is walking. Look at this. Very short steps. Okay, patient is trying to put very short steps and a stooped posture in order to maintain his center of gravity. Okay, if you appreciated the animation, let's move on to the next. Okay, then we have something called the waddling gait. Waddling movement you must have heard is the movement of a duck. The duck walks in a waddling movement. Okay, so duck-like gait is called as a waddling gait and seen in muscular dystrophy. Is seen in condition of muscular dystrophy. So waddling gait, remember, it is seen in muscular dystrophy. And let's see how the patient is walking here. Okay, just a wide movement. The patient will walk widely, like the movement of a duck. How is funny, right? Okay. After we finished all the gates, so we discussed what are the gates. We discussed spastic gate or hemiplegic gate, stampling gate, then drunken gate, Festinand gate, and waddling gate. So these six gates are very very important. Your teacher will definitely ask you this time. Okay, and you may be asked to demonstrate the gate. So just get free to act dramatically. Right? Just kidding. Okay, let's come to involuntary movement. This is again a very, very important thing and a very important concept. And here we'll discuss the tremors, fine tremors, then coarse tremors. What are they? We'll discuss involuntary movements. Involuntary movements means which are not under your control. And these movements, involuntary, are seen in patients with neurological or CNS disorders. Right. So first we have chorea, CHORE, chorea. You must have heard about a disease called as Huntington's chorea. Chorea in some any language I don't know means dancing, dancing movement, dancing movement. It literally means dancing movement. So we have rhythmic, jerky, dance-like movements. Rhythmic, jerky, dance-like movements. Okay, the patient will do like this, anything. The patient will dance. Okay, and you will see many people that they will be commenting that who possessed the person. The person आदमी को भूत लग गया है, and they say quite very nonsense thing. but the person is suffering from chorea. No need to worry, and the person is not possessed. The person, you can be assured that if you treat the person, you will be not possessed thereafter. Right? Okay. Then let's come to athetosis. Athetosis means writhing, worm-like movements. Athetosis means worm-like movements. This is important. Writhing, worm-like movements means the person will do like this, something like this. Person will do like this, worm-like movements. Okay, writhing movements. You must have heard about that Odissi one. Okay, that mudras and all. So athetosis means writhing or worm-like movement, and these are seen disorders of that globus pallidus and other things, putamen lesions and all. Okay, this may be seen. Just remember what are the types of movements. Then we have something called the tics, T-I-C-S, tics. That is frequent blinking of eyes involuntarily. The person will do like this, frequent blinking of eyes. The person will start to have a indifferent facial expression, which is a bit wired to see. Right? Just look at this GIF. Can you see the person? The person is involuntarily, the facial muscles are getting contracted. Right? Okay. Let's not see the person much, or else we'll develop the psychosis. Okay. Then comes to tremors. Tremors means your movement, which is like you can say alternate movements, but very fine alternate movements. Okay. The tremors are uncontrolled vibratory movements. Okay. So we have three types of tremors basically: one, two, and three. We have you can remember FIR. Okay. FIR for remembering tremors. So first of all, we have our fine and rapid tremors. Fine and rapid tremors. Okay, this type of fine and rapid. This type of movements are fine and rapid tremors. You must have heard, you must have seen many people doing that fine tremors or rapid tremors. So basically, in your thyroid disorders, in your thyrotoxicosis or the hyperthyroidism, this is a hyperthyroid condition, or in people with anxiety, in depression. Okay, some students also can develop this fine and rapid tremors. Okay, so fine and rapid tremors are tremors like this, and they are most commonly in anxiety-related disorders. If you are getting a panic attack, you get tremors, and in thyrotoxicosis and thyroid disorder patients, you'll get fine and rapid tremors. These are the fine and rapid tremors. Just look at this GIF. Can you see? These are the fine and rapid tremors. Okay, done. Then F is done. Then I. I means intentional tremors. Intentional tremors means the person, let's say, here I have a remote. Okay, here is a remote. My hand is normally like this. I am normal now. I put my hand on the table, if you can see. Yeah. Then I am normal. My hand is just resting. It is not showing any kind of movement. Then I will try to grab this remote out of this hand. I will try to grab this remote. What a normal person do? Normal person will go and simply grab the remote and put it here. Right? But a person with intentional tremors, if he makes an intention that I have to grab this remote, if the person hand is relaxed like this. But if he tries to go here, then tremors start appearing. Then tremors start appearing. Okay. Means we, if you make an intention to do this and do that thing, if this stylus is just you can see, if this stylus is present over here, my hand is now normal, but if I try to grab this stylus, then my hand will start tremoring. Right? This is about intentional tremors, and it is seen in cerebellar ataxia. So cerebellar ataxia has many things like intentional tremors are present. We have a that gait in ataxic gait is present. Okay, it was been called the reeling gait. So intentional tremors. Then we have something called the very characteristic tremor. Is called as resting tremor, pill rolling tremor, or drum beating tremor. All three names are very, very important, or Parkinsonian tremors. the resting tremor, pill rolling tremor, drum beating tremor. These three names correspond to one type of tremor. Okay, intentional tremor, did I show you? Just look at that. The person is asked to grab this pen, patient, and the tremoring is occurring as he goes to grab the pen. Right? It is intentional tremor. Okay. I was talking about resting, pill rolling, or drum beating tremors. So here we get 6 to 8 cycles per second. 6 to 8 cycles per second is the frequency of tremor. No need to remember this. And seen in Parkinson's. So basically, if your examiner asks, what are the types of tremors you know, you will first will find and your fine and rapid tremors. Okay, then you tell intentional tremors, then you tell you're resting a pill rolling or drum beating tremors. You should tell these three names because these three names are from different books. Different books write them differently. Okay, and this drum rolling tremor is specifically mentioned in the Ganong. So your examiner will have a good impression upon you to tell this. Okay. So it is seen in Parkinson's. Parkinson's, is a neurodegenerative condition in which various things happen. Cogwheel rigidity will happen. The person will be stooped. The person's facial expression will be masked. The person will have a statue-like face. There will be lead pipe rigidity. There will be cogwheel type of rigidity. This type of rigidity, right? And various other things. So resting tremors, what will happen? The person, if the hand of the person is resting upon this table, then it will start tremoring. It will start tremoring. But if I do something, if I do like this, then no tremors. If I hold this remote, if I grab this, if I am doing an activity, if I am moving my hand, if I am scratching this, no tremors. But if the person hand is resting, just the person hand is resting, then it will start tremoring. And this tremor is a characteristic type. The tremor will be like pill rolling tremor. Pill rolling tremor means, let's say here I don't have a capsule here. Okay, let's say I have a capsule over here, a medicine or a just a capsule over here, and I roll it between my hands. So the tremor will be like this. There will be rolling type tremors. This type of tremors, pill rolling tremors. A classical pill rolling tremor are seen in your this Parkinson's. Okay, so this is the thing, and here I have this GIF. Look at this. uh, you can imagine the person holding a pill, holding a medicine pill, and rolling it between his fingers. Pill rolling tremors. Okay, if you can, here's the capsule, and the person is rolling it between his hands. Okay, just to an analogy. So with this, we come to the end of the motor system examination. Reflexes is a separate topic. It is not characterized under motor system examination. These things you have to check in motor system examinations of a patient. If you are examining the motor system of a patient, this few things you have to check in the patient. Okay, and reflexes eliciting the knee jerk reflex, eliciting the ankle jerk, eliciting the tendon tap, the Jędrusik maneuver. All those things will be dealt in a separate section, which I'll take when I get free. I don't know when I will get free and all. Okay, no problem. So I hope you enjoyed the lecture. I tried to make this topic a little bit more interesting. I tried. Okay, I can't guarantee. Feedbacks are always welcome, and for any other topic or demanding, but I'm getting very less time to cover up the topics. Based on the demands, I will try to cover it up whenever. And if you have any doubts, you can reach out to me on Insta. This is my Insta ID. I hope you will enjoy today's lecture. Okay. And if you haven't subscribed the channel, do subscribe. I'll be putting a variety of things in future also because it is my permanent channel, and here we'll try to cover up as much as possible concepts in your MBBS curriculum in a fun way. So that's all in today's lecture. It's time to bid adieu and say goodbye. Thank you and have a great day ahead. Always it's afternoon. No problem.